Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. All right, everybody, let's do this. Hello, we have Dr. Hockel here. How are you, Dr. Hockel?
Great. Good to be with you.
Thank you so much for being here. I'm really looking forward and honored to having you on this podcast interview. And I've seen you present multiple times before, and I feel like your information is so enlightening, talking all about orthodontics and the role of orthodontics and different treatment plans and ways to get similar results. So one of the things I've learned from you is there's different ways to achieve a certain goal. There's different orthodontic techniques in different ways. And this concept of like camouflaging is really interesting to me. I haven't heard that so much from other people. So I definitely want to learn about that and how you're an airway educated orthodontist. So you think not just from an aesthetic cosmetic focus, but really helping patients enhance their breathing, growing the jaws forward, widening the jaws, thinking of the whole body as opposed to just the teeth, but thinking of the body connected to the teeth. So we're going to learn all about Dr. Hockel is going to present on the place of orthodontists and the whole health paradigm, or the place of orthodontics and the whole health paradigm. And I'm going to go over your bio and I'll ask you a couple questions and then we'll give you all that time to present. So Dr. Hockel is a graduate of UCSF School of Dentistry and following in his father's footsteps has been practicing orthodontics for 25 years. He focuses on treatments which protect or enhance the airway. I love that, actually, protect or enhance. So kind of like that thought, do no harm, right? You're going to do your best to enhance the airway, but at least protect it, not to make things worse. I haven't heard that much, protect or enhance the airway. Having taught an airway orthodontics mini residency, he's also been an instructor for and a board member of the Academy of Airway and Anathologic Orthopedics, which is the AAGO. He's a founding member of the North American Association for Facial Orthotropics, the NAAFO, and he teaches hands-on orthodontics for the Early Childhood Health-Centered Orthodontics, the ECHO mentorship with Dr. Bill Heng. Dr. Hockel has lectured nationally and internationally on non-retractive airway orthodontics. Your hobbies include playing bass in 2 bands, which is awesome. So fun to watch you outside your orthodontic profile, playing in the band. And you're also in the Pulmonauts, which is like the sort of airway sleep medicine group of musicians that got together, which is really fun to watch you all kind of jam after like doing all these lectures and all this high-tech information and teaching everyone, and then y'all just cut loose. So great. So Dr. Hockel, you live in Walnut Creek, which is Northern California, with your wife, Beth, and various numbers of your 11 children. Woo! Big fam. That's great.
But there's only 3 at home right now. We're like empty nesters with only 3 at home. It's so much easier.
That is the funniest thing. Empty nesters with 3 at home. Oh my gosh. So 8 are gone. 8. Oh my gosh.
Yeah. One just got married 2 weeks ago. So yeah, it's great.
Yeah. Congratulations. How is that? 11 kids. How is that?
Well, we're Catholic, so we kind of started out with the idea we'll let God pick. And my brother did the same thing and he got 0. So you really don't know when you put it in God's hands. And so, yeah, we didn't start out with any number in mind. We just kept asking, can we be responsible and continue with this? And we ended up with 6 boys and 5 girls. Yeah, 3 of the first 4 were girls, but then the next 5 in a row were boys. So they were kind of like the baby boomer generation that just kind of created the whole culture of the family based on what those 5 boys did. And it was a lot of fun having them all at home, but it's kind of nice having a little more predictability with where you put things at home nowadays.
Oh my goodness. What a cool story. How fun. And it's kind of like you have a whole sports team, a soccer team at your house when they were all there. Yeah. What a fun, what a neat thing. Well, that's really
against me, they play against me a lot of the time. Yeah, today's 35 years since we went on our first date. So shout out to my wife. She's really the one that makes it happen. I mean, I get up and go to work like everybody else, but she's the superhero that ran the household, homeschooled, did everything necessary to make it work, and she's a saint to this day. Really great person.
How beautiful. That is so wonderful. So great. 35 years ago from today, first date. And today's Valentine's Day. So that's really, really special. So great. I love hearing all about that. So before you get started on your presentation, I want to know, I always find it interesting how people got started in their fields and their careers. And I find a lot of dentists and orthodontists that I talk to, it was like a family affair. So they have family or parents, who were in the field. So how did you decide to become an orthodontist? And then also that additional step of specializing in airway treatment. Was there an aha moment for you? How did that happen?
Right. Well, first of all, I'm a general dentist. I'm not strictly speaking an orthodontist, but I do nothing but orthodontics. So you could call me an orthodontist or an orthodontist with a small o. I'm careful because the specialty really wants to guard that title. And so anyway, yeah. My two aha moments, because there are in I think everyone's career moments you can identify that really change the course of it. The first one was when I realized that my dad, whose idea of an ideal retirement was doing nothing but orthodontics while I ran the general practice. And I realized he wasn't going to be around long enough to treat all of my kids. And I thought, I'm not going to refer them to the specialist because I've seen what happens. And I was very fortunate to have my dad as a mentor and always on hand in the office with me to take care of the orthodontics for all my patients. So that was what made me decide, okay, I've got to learn orthodontics. That was about 1998. And then it was about 6 years later was the next aha moment where I thought I had so much figured out. And I met Bill Hang, and he did this kind of orthotropic lobotomy on me and many of us to help us realize that what we thought we were getting with our treatments, especially with class 2 cases where the mandible and the maxilla, turns out the maxilla too, were all retruded. And I was using a Herbst appliance. I had used a twin block, Bionator, other functional appliances. But the big aha moment with Airway was when he opened my eyes to the fact that we were all retracting. We were all doing things that were giving the tongue less room, and in the end, probably closing off the airway. And I went back and looked at the x-rays of some of my cases, and I found that. And I think in the presentation today, I've got one of those cases here. So I have him to thank and blame for everything that happened after that. And my wife will tell you, I was not in a great mental state in those years because I was having to rearrange everything that I had been taught. Not everything. I mean, my dad was very non-extraction oriented, and he worked toward better oral posture. And he has a chapter in his book from 1981 on myofunctional therapy and on cranial osteopathy. So he was way ahead of the profession in a lot of ways. So I had that as a good starting point, but still there was a lot that I had to relearn when the biggest consideration became looking at the airway in addition to everything else.
Yeah, it just seems like to be that open-minded is such a blessing because so many people are narrow-minded and stuck in their ways, or that saying, don't let your education get in the way of your learning. And that's what holds people back from really progressing the field and making change. And it sounds like it's so hard to make that change once you think a certain way, right? To open your mind, like you said, rearranging your brain. It's like, whoa, everything you taught might not be correct, or there's other ways to do things. And now you're at this advanced level that you can help people in ways beyond just very basic,
Yeah.
treatment of the teeth ways. So I think
the truth has kind of a power of its own. When you hear something that's true, it just rings in you. You can't get rid of it, and it takes a lot of willpower, or I don't know, being in a state of denial to suppress it and just keep doing what you're doing despite what the truth is. And I think the way that Bill Hang taught and still teaches was clear enough that there's like no denying this. He's right. I mean, this makes sense. And it's just on principle. I have to just change what I'm thinking and what I'm doing. That was easy, but then changing everything was not so easy.
Right. Going through the nitty gritty part of it. But it's like everybody says, once you see it, you can't unsee it, almost to the point where it's so obvious. You're like, how come other people can't see this, right? It's so obvious. So you have no choice but to follow that route. When you see how the oral structures affect our breathing, affect our body, affect our sleep, our whole health, it's so obvious that you have to take that path. And we all call it like that rabbit hole. So I wanted to talk to you about malocclusion and what you feel is the cause of malocclusion. Big question.
I don't like the question, because the question sort of assumes a mindset that orthodontics has had for a long time, which is that it's really all about the malocclusion. And you'll see case reports in the literature where we say, how would you correct this class 3 malocclusion open bite? And this is one of the biggest changes in thinking, is that it's not just about the malocclusion. The evidence we have that malocclusion causes problems in and of itself is not that great. So that's kind of, there's an agenda behind that question about the cause of malocclusion that I think misses a lot of the point of what we're really looking at. But I think the answer to your question, so far as we understand it, is easy and really hard. The easy part is it's related to our altered rest oral posture and how we use the muscles of the jaws, mouth, tongue, etc. But then the hard question is, well, why is our oral posture altered? Why are we not using the muscles the way we should? How should we be using them? And we know glimpses of this, but I feel like we don't really know everything we need to know about this. We know that breathing method makes a difference. We know that tongue posture, especially if it's related to any kind of tongue ties or lip ties, we know those can have an effect. But we really don't know how and when. And so I think there's a lot we don't understand yet. But I don't think it's as genetic as most people would say. Having seen the dramatic change in the last 300 years since the industrial era, it can't be evolution, if that is even really taking place, and it can't be purely genetics. Just 2 weeks ago, my son's wedding, there were 2 women in the bridal party who were identical twins, and the jaw structure and facial shape was so different that I had to comment to someone, well, I think we know which one was a mouth breather, probably. And the person knew them well enough to say, yeah, how did you know? That's right. So it's not as simple as just saying it's genetics. And the whole idea that if we just modify genetics, we'll have straight teeth. I mean, work on modifying genetics to correct baldness. That'll probably be more important, because I think the rest of it is really more about how do we modify our environment and how we use this part of our body right here so that the teeth develop in a straight way.
Yeah, and it's so amazing for someone who practices in the line of orthodontics or dental orthodontics, as you call it, with a small O of orthodontics. You're moving teeth, moving the jaws, changing the structure, which will help with better breathing. But you have that understanding that the soft tissues and the way our oral resting posture is, or our rest oral posture, will impact the way the face grows. It's not just genetics. And I've talked to orthodontists before who have kind of like shunned that whole sort of epigenetic or muscular piece and just say it's just genetics, like dad's teeth, mom's jaws, and that's how it is. And it's like crazy. And I've had orthodontists who actually refer for myofunctional therapy, but have told me that, which I'm like, that doesn't make sense then. So how are you?
No, exactly.
It's like a partial understanding.
Exactly. So, and there's no evidence for the dad's jaw, mom's teeth thing, or the other way around. Not only that, but if you just look at how genetics works, how you inherit different traits, it wouldn't make sense for that to happen the way that we're kind of attributing it. It's just an easier answer to say it's all genetics. And in fact, mom looks like daughter and they look like grandma, and you look at the pictures of the Habsburg family in Austria, there are traits that we see continuing through from generation. But is that because they had similar uses of the muscles, similar oral posture? In fact, maybe just by imitation, the child might imitate the parent's oral posture, and then that leads to a similarity in the growth. So it's not as simple as just genetics.
Right. It's very complicated, but there's so much to the environmental components also. Like a child could nurse for 2 or 3 years, but still develop malocclusion from soft tissue dysfunction because they used a sippy cup, right, for 3 years also. So it's not like a perfect one-to-one relationship. There's so many muscular factors in the way we function, and you could do great and then all of a sudden develop really bad allergies and become a mouth breather and things change. So there's so many pieces to the environment, and that's why I think in all of our evaluations, we're so detailed at looking at all of the factors and knowing how our treatment, we have to intervene in a holistic way. We have to look at the way a person breathes, the way the foods a person eats, how they eat, the mechanics, tongue tie, like the whole aspect. So what I think is great about you is you work with a lot of myofunctional therapists. How did you learn about myofunctional therapy and begin working with myofunctional therapists?
I remember as a early teenager, it might have been even around age 9, 10, going to a guy named Mr. Brown, and he had a little office in the middle of the dental complex my dad worked in, and he would squirt water in my mouth and watch how I swallowed, and he did myofunctional therapy. So this was a part of my dad's practice in the early 70s, and he was connected with Bill Zickafoos, and I remember, going to Bill and Julie's house here in Placerville, and so it was kind of in my world, thanks to my dad, for the longest time. But the change that came about in meeting Bill Hang and kind of looking at the oral posture element is that it was less of a function and less of an emphasis on function. It wasn't all about tongue thrust. It was really more about altered oral posture. And so that from the beginning, that was always on my radar. But I think it wasn't until I learned about orthotropics and more about John Mew that I saw, this is really the key to the whole puzzle here. Is if you ignore the myofunctional dysfunction, then it's to your own peril.
Mm-hmm. And that's true. It's really that resting position, that light continuous force that's going to impact the occlusion, the way the jaws grow, but also the thrusting, that quick motion during a swallowing pattern or a speech pattern doesn't necessarily impact the teeth, the alignment of the teeth, the way the jaws grow, but it will change and alter muscle tone. So in myofunctional therapy, we do address both, right? The movement patterns, because you have to, right? Exactly. But it really is that oral resting position, that oral rest posture, rest oral posture, as you say, that's really going to impact that long-term growth of the jaws, the alignment of the teeth. And it's paramount that that's what's corrected in myofunctional therapy. And in orthodontic treatment, do you feel that all orthodontic patients need myofunctional therapy?
Yeah, pretty much all. I mean, if they're an orthodontic patient, by definition, there was a problem with their rest oral posture, and that should be corrected. It becomes more critical the more growth is still remaining, but it's still important even for adults who aren't growing for the sake of stability, for the sake of comfort, for the sake of the airway, for the sake of aesthetics of the face. There are a lot of other benefits that are there beyond just altering facial growth. But yeah, I think by definition, if someone's an orthodontic patient, they're a myofunctional therapy patient.
Yeah, that's great. It's great information. It's sometimes awkward as a myofunctional therapist if we're going to like lecture or do a lunch and learn for orthodontists to teach them to be like, all of your patients have a myofunctional problem, almost like we're trying to recruit patients, but really it's like, yeah, it's the understanding of the root cause of these issues is what we want to treat. And I think it's important for people to realize myofunctional therapy is not some like magic pill, some secret sauce. It's just restoring what is normal, what should have been. There's no side effects to treatment. It's just, we're just getting the lips and tongue to rest in the correct position, appropriate dental freeway space, correct chewing and swallowing patterns. And that works so well into the orthodontic treatment, into your nose and throat treatments, medical aspects, allergy aspects. It's just a whole picture of health. So before you do your presentation, I know you're going to talk about different orthodontic approaches. What is the youngest age that you begin to treat children for orthodontic aspects or airway, skeletal, craniofacial components?
I think around age 3 would be the youngest, given all the right factors, the right parents, the right family, the right cooperation, the urgency of the need for the treatment. Typically, it's going to be around age 3, maybe toward the later threes.
Okay.
But kids can really vary. So yeah.
Which is amazing because most traditional thinking practitioners aren't even going to consider till age 8, 9, 10, 11 or beyond. And
yeah, it's way too late.
And so many people I interview and talk to, age 3, 4, 5, some even age 2. And people who aren't aware of the impacts of poor breathing on sleep and health probably think that's ridiculous or that's crazy to start that young. But people like you and people who have this understanding say those 8, 9, 10-year-olds are like geriatric patients, which is just a funny thing. I was just talking with Kevin Boyd, and he was saying that as well. So how do you know when a child needs intervention?
It's not just when would we start orthodontic treatment, but when do we want to see them? That would be even earlier. Yep. I mean, I read my letter to parents of a new baby recently saying, even right away as a baby, let's take a look. There are things like looking for oral ties, like just counseling the parents on proper breathing, proper posture, and things to avoid for the sake of the baby. So even though treatment orthodontically might not begin until 3 years into it, 3 to 4 years into it, there are other things that are important before then.
Yes, because
we just have to reimagine the orthodontic field.
Yeah, and a lot of these problems can be identified really early, potentially at birth or even at the first dental visit if someone takes their child at the age of 1 year to the dentist. So I'm on this child airway screening task force team where we're developing a universal screening tool that dentists will use to screen children. I believe it's beginning at the age of 2, but my son, and I think it's recommended, children see their dentist at the age of 1 year, right? Isn't that the recommendation? So it's really,
I think that's great. Yeah.
Well, the funny thing is, I brought my son when he was 1 year old, and he definitely had a lot of myofunctional issues, breathing issues, but I didn't know at the time because I wasn't educated in that way back then. And the dentist takes a picture of each child at their first visit, and you get like, oh, here's a photo of your kid, their first, and it goes on the wall or whatever. Well, I happened to save that photo, and I looked back. Now, knowing what I know now, you can literally look at that photograph, and you see venous pooling, open mouth posture, drool all over his shirt. And it was drool before they even did any treatment. It was already when he walked into the office. These baggy eyes. And I'm like, wow, we can identify these things in a 1-year-old at their first dental visit. And that wasn't even looking in his mouth yet. Just did a photo of the face.
1 week would be, if you're setting dates, I'd say 1 week is better because then you can look for the ties and talk about other important stuff. And they're kind of past that initial few days of a new baby in the house, and they're going to be a little more open to listening at that point. And they're probably a little bit sleep deprived from the first week and a little more desperate to look for things that could help alleviate that.
Yeah. And there's so many, like you said, signs that could be at birth, first week. And also people can develop myofunctional problems and malocclusion at any age in their life, depending on how their resting oral posture is and how they're functioning. So let's get into your presentation so I don't talk too much because I really want to learn all about different orthodontic techniques and the whole health approach. So if you just like present, your screen will come up.
I will do that.
All right, there we go.
Okay, so the theme of this is where orthodontics really stands if you're looking at it as a part of our overall health. And I took this picture from an airplane my son was flying. He's got his pilot's license, and I got to take that. I'm in east of San Francisco in Walnut Creek. And that's a picture of the group of us that learned orthodontics, starting with my dad and kind of through a lot of other areas. But general dentist, Walnut Creek, finished in 1989, and I practiced in a little farmhouse out here in Walnut Creek. So the question is orthodontics really anything different from fixing up our hair? And is it really just lining up our teeth, or can it really have an impact on our overall health? I mean, there's a famous orthodontist who said there are no diseases associated with malocclusion. And here again, it's kind of that issue of malocclusion. But if we admit that sleep has a huge effect, and maybe it's the single most effective thing we can do to get our brain and body in good overall health, you think about if we cut out water, cut out food, cut out exercise, cut out sleep, you can't even go 24 hours without having a major issue with your brain function and overall health. So sleep is super important for our overall health. Or Casey Means talks about how interrupted sleep has an effect on blood sugar and diabetes, makes it more likely. So sleep definitely affects overall health. I don't think anybody would argue with that. So then you say, well, does the structure of our airway impact our sleep? And there was kind of a pro-con discussion here where one doctor said sleep apnea is from the anatomy itself. It's a structural anatomic disorder. And the other doctor said it is not an anatomic disorder, that there's a neural compensation that's underlying the whole thing with sleep breathing problems. And I don't know, I mean, if you look at the two people themselves, you kind of say, he better hope it's not an anatomic disorder, because there are certain anatomic things like the larger neck that we know makes it more likely. But the discussion was, hey, everything we do to help sleep apnea changes the structure. It's basically whether we're doing CPAP, weight loss, oral appliances, all of those therapeutic options are to alter the anatomy, the structure of the airway. So really, overall health definitely is affected by sleep. Airway affects our sleep. I don't think anyone doubts that. So now the missing link seems to be, well, can what we do in altering growth or dentofacial orthopedics and orthodontics, can that affect the airway itself? There are a whole lot of other things, of course, that affect these things. But if you look at kind of the sleep and airway pie in the middle there, orthodontics has to be a part of that pie. Myofunctional therapy is definitely there, oral appliances, CPAP, a lot of things we do to help sleep overall. And if we just kind of take out the orthodontic piece to the pie, that's what we're going to look at now in this presentation. The things that within orthodontics we can do that we can help that anatomic structure of the airway. And really, if we break it down, here are the different areas that we can affect. We can do things in orthodontics that will enlarge the nasal airway. We can do things that will enlarge the space that the tongue has. And considering it only has so much room between the front teeth and the neck bones, having more room for the tongue in there can have a huge effect on the function of the airway. We can do things to at least just hang on to the space that the tongue has, or we can do things that can move the jaws forward. So these four areas where we can have an impact, to me, form this Venn diagram, so to speak, of how things overlap. A really big one is enlarging tongue space, but we're going to kind of break it down in this overview into 11 different strategies that affect these different areas of the anatomy and can affect the sleep, and that can affect the overall health. So we're going back a few steps here. So if that makes sense as an introduction, let's dive right into expansion, or arch development is probably a better term for it. When we in orthodontics do expansion or arch development, we either do it with a side-to-side direction of change or in a front-to-back direction of change. So it's either transverse or AP. And it seems like right now, the whole airway orthodontic world is all about transverse arch development or expansion, one way or another. And I think that's it's important, but it may be missing out on other things that are just as important, really. So if you're going to just focus on transverse arch development or expansion in the mouth, then go ahead and keep doing that. But the whole purpose of this presentation is like, what else is there beyond that? We can break transverse expansion into appliances that attach to the teeth, dentoalveolar expansion, and appliances that aim more for skeletal change and altering of the bony structure. So let's take a look, first of all, at dentoalveolar expansion. What is that? This is probably the most common thing. Everyone's familiar with this. Various types of appliances generally attached to the teeth, either removable or fixed, and they widen the arches, but they're increasing the tongue space. This may not be the thing that everybody realizes they're doing when they do this, but by getting the tongue more room, it makes it more feasible for the tongue to learn how it should posture and how it should function. And when you do this at the right age or in certain ways, it has the potential to enlarge the nasal airway too. So here's a before, and then on the upper left, and appliances on the upper right there, showing a removable upper expander and a fixed lower expander. And then on the bottom pictures, it shows after arch development. And again, the whole purpose of this is increase the amount of room that the tongue has. So the arches before on the top picture and then after on the bottom picture. And this is a non-grower. So this can be done for patients who are beyond childhood. There are various types of appliances to do this. And the purpose of today is not to talk about all the different appliances. These are common ones that I like to use. And some are removable, some are fixed and attached to the teeth. And there are a lot of criteria that go into the selection of the type of appliances that are used. I'll just show you one quick before and after. This is a 3-year-old. We're talking about, when do you start? With obvious crowding. There's should be more spacing between the primary teeth. So this is obvious to those of us who do this. But to a lot of people, and certainly to a parent, they would think, yeah, those teeth are nice and lined up straight. They look really good. We used a Crozat in this boy's case, and this shows when the Crozat was delivered, and this shows a while down the road. So I'll go backward and show where it's narrow, and then forward to show where it's wider. And the Crozat applies the light force. We adjust it in the office every 6 weeks, and he's got a lot more room for his teeth and a lot more room for his tongue at this age. So when you see as more permanent teeth come in, we're holding on to the transverse expansion we got. This is where there becomes a little blurring of this category of denoalveolar versus skeletal, because it seems to me like there's a false dichotomy that's been put out there, a false alternative. In logic, they call it the fallacy of false alternatives. Option 1, you're tipping the teeth. Option 2, you're splitting open the suture. That seems to be the 2 alternatives that are out there in the whole airway ortho world. And the term is used, true expansion. Yeah, you're tipping the teeth, but are you getting true expansion? But I think there's a third option here, and that is you can modify the way the suture is formed and the way it grows by doing gentle, slow expansion with these denoalveolar techniques. And you know what? If our goal is to enlarge the nasal airway and enlarge the tongue space, really when it comes right down to it, does the tongue really care how we increase the space that it gets? Even if there is some tipping of the teeth, that may not be a total disqualifier for whatever method we chose to do this with. So getting the tongue more room, yes, you might be tipping the teeth. That, number one, that might not be so bad just in and of itself. Number 2, splitting open the suture, that's always good. But you also may get sutural change. So here's that boy that I just showed you with his Crozats. We carefully lined up the CBCT planes and we made some measurements, and we're looking at the upper and lower primary second molars. So those are the arrows that are in the mouth there. And if we compared his before treatment to further down the road, this is going a little bit down the road, and we look at just the primary second molars on the upper E's as we call them. They went from 23 millimeters to 36 millimeters. That's a huge difference in width. Now, here's why I'm showing this picture. Does it look like all we did was tip the teeth? It's possible to do this in a slow, steady way that's not just tipping teeth. And obviously, we don't really care about straight teeth. We're using the primary teeth as a handle to the bone above them to change the shape of the jaw. And on the lower, look at the lower E's. They went from 22.5 to 34.5. That's 12 millimeters of change. And you don't see those teeth tipped outward. In fact, they look like they're tipped inward slightly. And you can, of course, go in there and measure the buds of the teeth that haven't even erupted in the mouth yet. And they've changed dramatically in their dimensions as well. So I think, in the case of something like this appliance, and there are others too, this isn't the only one, the growth can be altered in a way where you are getting true skeletal expansion if you do this at the right age and the right way. And I don't think we can always predict exactly how it happens, but I think the bottom line is probably just doing it slowly.
Can I ask a question about that?
Go ahead.
So that's in a growing child, you can use dental.
Yeah.
Okay. What about in a non-grower? Can you
see it in non-growers as well, but it's harder to predict. It's harder to control. Appliances that go very slowly over time, you are going to get more tipping of the teeth with denoalveolar expansion. That's a given. Teeth will tip more. But you can also get some changes to the shape of the palate that kind of look like a nice broad, flatter palate here with expansion, even with adults. So it really shouldn't be, oh, are you tipping the teeth, or did you really get true expansion and split the suture open?
Okay. Just to clarify one thing, so I understand though, for an adult, like, can you enlarge the nasal airway? Are you getting sutural expansion? Can you with dental alveolar arch development?
Yes, you can, but I
Okay.
can't tell you exact. It's going to be less, and it's
Okay.
going to be less predictable,
Okay.
and it's not going to be as good as the stuff we're going to talk about now. So
Okay.
if you really do want true expansion in the nasal cavity, then skeletal expansion is, especially in today's day and age where we have much better options. This is obviously the better way to go.
Perfect.
But I don't like the way that it's kind of minimized when we say, oh, if you're not splitting the suture open with pads, well, then all you're doing is tipping the teeth. Yeah, well, number one, we're not doing just that. There is some degree of remodeling of the bone there. And number two, we are getting more room for the tongue either way. And the tongue doesn't care how it got more room. It just likes having more room. So we have to stop thinking that that's the only positive effect we can have is splitting open the suture, either in a young kid with rapid expansion or in adults, even where we're doing it slowly. However, when there's an airway issue, obviously this next section here on skeletal expansion, it's way better to be able to do it this way. Does that make sense as an answer for you?
Perfect sense. I really appreciate that explanation.
Okay. So skeletal expansion, let's dive into that. This is where we use temporary anchorage devices, otherwise known as TADs. And so mini screw assisted rapid palate expansion is abbreviated MARPE. And the letter R in it is a problem because the trend now is toward much, much slower expansion, slower than even when you did it, Nicole. But so I've replaced that R for respiratory. I like to call it mini screw assisted respiratory palatal expansion, just to give it another meaning to the R in there. So these are appliances that attach to the palate by means of those screws, or when we're talking to a patient, we call them anchors. So you anchor the appliance to the bone. Or the other way of getting skeletal expansion is to have a surgeon make some cuts to the bone, and this is called a surgical assist. When you surgically assist the rapid expansion, this is called SARPE. So MARPE and SARPE are the two ways of getting the bone to widen on the upper jaw. Three appliances that are out there that can be used for the MARPE type of expansion are the MSE, the maxillary skeletal expander. This still has a good use for kids and some teens, but it was the appliance that Juan Moon promoted and kind of became the standard for doing types of MARPE. But it really was terrible when it came to using it for adults, especially adult men. The Facegenics maxillary expander is the picture in the middle there. It's got more limited use. I'm not going to go into detail about it. But the custom MARPE on the right side, the 3D printed custom MARPE, is now becoming the standard of care, really. You can plan out where all of the direction of the mini implants are going to go. You can design where, how the forces are going to be applied by changing the angle of the screw. There's a lot of variables that you can control with this. They fit beautifully when they're made on a model of the printed models that we do with the intraoral scans. Here's an example of a MSE type of a MARPE and showing an open bite. Why is the open bite there? Because the tongue has nowhere else to go. It's not that she's got a tongue thrust, it's that the tongue needs somewhere else to go. So the MSE is able to create that space on the palate there, and going at a rapid rate, you do see that diastema between the front teeth. Now that we go to slower rate, it doesn't tend to open as much like that. In fact, I had somebody in this week that said he was worried because he didn't feel a pop and get a big space between his front teeth. And I said, that is okay. You're getting the expansion. He was already like 6 millimeters wider than when he started. So then the bars to the teeth can be disconnected, and the braces can be used to align the teeth, or aligners, whatever you want to use. And this is that patient before and after doing skeletal expansion with the MSE type of a MARPE. There's the lower.
For the MARPE, if you're doing slow expansion, the newer protocol of slower turns, and you're not really getting much of a diastema, is that because the teeth are naturally going to migrate medially?
Yeah, they're connected by the interseptal fibers in the gum tissue. Yeah, so it's like rubber bands holding the teeth together. And the fast expansion, you overpower those rubber bands, everything's moved apart, and then the rubber bands kind of bring things back together. And you can see the front teeth tipping toward each other in that second picture here. That's what you tend to see even before the braces go on. You get the big space, and then they start to pull together with the gum tissue. But when you do it more slowly, you don't see as much of that.
Okay.
So you're going to be limited on how far you can expand the upper if you don't expand the lower. So here again, oh, but you're just tipping teeth. Yeah, well, you know what? The tongue doesn't care, because look at how much wider that arch is. Do the teeth look like they're unnaturally tipped outward? We don't like to use the word expansion with the lower, so we soften it with the term uprighting. Oh, we're just going to upright the lower molars, or we're going to just decompensate them. They're just tipped inward because of the narrow maxilla, so we're going to decompensate them. Fine. If it makes you feel better to use those terms, you can. To me, it's still arch development or expansion, all the same. From the tongue standpoint, it's getting more room. Tongue doesn't really care how it got more room. So there's the smile before and after. She really needs double jaw surgery. The whole maxilla is down farther than it should be, but she likes how there's more room for the tongue. It's able to fit in there. For adults that have a palate where there's a very thick width to the bone in the middle of the palate, or especially for men, different situations, using a piezo corticotomy and just doing a slight slit. We actually don't do it as far front to back as this picture is. I have a new one I need to put in here, but this can help make it much more predictable. The custom Marpy like this, oh my gosh, it's really opened up options for us that we didn't have before. So, I mean, in the past, I came up with crazy designs. I used an MSC along with a second expansion screw, along with 4 more TADs, and it worked in those cases where the MSC failed. But it's so much better not to have to worry about that kind of craziness, and put the TADs where they're going to be well anchored in bicortical bone, and they can have the effect they need to have. And you can get this kind of a change where the tongue has enough room compared to where it started out from before. So we're still in the category here of enlarging the tongue space and enlarging the nasal airway. So let's look at the nasal airway. Here's a case of a young boy who had severe sleep apnea at age 10, and the nasal airway went from 22 to 28 millimeters across the bone there. So it does both. That's one of the great things about skeletal expansion like this, is it has the potential to make more room for the tongue downstairs and more room for the nasal airway upstairs. So the second kind of transverse expansion you can get at the skeletal level is a SARPI, a surgical assist. This is rapidly becoming unnecessary, but here's a video kind of showing how, you know, the surgeon can mobilize it to where there's room for the bones to move. And doing a surgical assist is what's behind the dome, the ease, the 2-pen, the mine. These are all variations of ways for the surgeon to go in and make different cuts that can facilitate the expansion. But I love how Stanley Liu says they're all the same. They're all the same. He's the one that came up with the dome. So surgically assisted maxillary expansion is what all of these are. And like I said, they're kind of becoming more obsolete. But we've got to put that in there. Transverse expansion, denoalveolar expansion, and then skeletal expansion, either with a Marpy or SARPI. Those give the tongue more room, and they enlarge the nasal airway. And like I said, in the airway ortho world, you would think that this is pretty much all there is. Regardless of the type of appliance you use, or whether you do it with surgically facilitated ortho treatment, or however it's done, it seems like that makes up the bulk of the world around us. So let's look at the second category in that bubble there, which starts with AP expansion, just kind of generically. What is AP expansion? Well, first of all, we've got to kind of take the nasal airway benefit out of there, because it doesn't really affect the nasal airway. It is giving the tongue more room. All of these other appliances and methods we've been talking about up until now work by expanding side to side. That's what transverse expansion is. But if our growth direction really has been unfavorably going in a more downward and backward direction, then that's probably not enough just to do the side to side expansion. And it was Bill Hang's phrase that he coined, that you can't solve a front to back problem with a side to side solution, that really kind of explains the importance of this whole aspect of it. We often, almost always, forget about the AP dimension. A long time ago, Bob Kernot was a dentist down in Solvang, California, who designed a Crozat variation that brought the front teeth forward while it was widening in the back. And I was going through old models in the basement of my office, and I found this case here where not only was side to side expansion done, but AP development was done, bringing the front teeth more forward, to the point where really little tiny bridges, these were gold bridges with resin pontics on them. I think I actually did the lab work for several cases like this for my dad. He was doing this in 1979. I mean, this is not a brand new type of strategy to consider, but applying it in the airway world, it takes on a whole different light. So what is it? What's AP expansion? Anterior, posterior, the front to back dimension of movement. It's one way of addressing that front to back problem, watching that skeleton grow down and backward. We're not undoing the skeletal growth, but we can have an effect on the front to back issue. Basically, we're proclining the anterior teeth. This is a sagittal appliance that is probably my main workhorse when it comes to AP expansion. It's unusual to design it like this, where it's only bringing 2 teeth forward. Here, this is not uncommon, where it's bringing 4 teeth forward. It's proclining the 4 anterior teeth, creating space for the blocked out canines. Or how about advancing 6 teeth at a time? Or commonly, we'll go from first bite to first bite and advance 8 teeth. So we talk about advancing or proclining. It's moving the front teeth forward. It definitely increases the tongue space. This is something that is a huge strategy within here, the enlarging the tongue space. And if we forget about the AP dimension, we're losing out on the opportunity to really get the tongue a lot more room there. But it also does this thing, it prevents or it can relieve mandibular entrapment, which you may or may not have ever heard the term mandibular entrapment. But what happens when you pull front teeth backward and there are spaces between the teeth, or let's just say you use class 2 elastics. I'll ask a lot of patients, when you had orthodontics, did you put rubber bands on from the top in the front to the bottom in the back? It's a very common thing we do. And it pulls the front teeth backward on the upper. But if there's no overjet for them to come backward into, this is what happens. The entire mandible goes backward, and in the joint itself, you'll commonly see x-rays that look like this, where the condyle of the mandible is pushed backward toward the ear canal. This is called mandibular entrapment. Something is preventing the lower jaw from being in a more physiologic, comfortable, better for the airway, better for tongue space, further forward position. And we do this a lot with the stuff we do in orthodontics. So we're going to come back to this and talk about it a little bit, but a person is twice as likely to have TMJ problems if the condyle is in that posterior position. So the 2 good things, increases the tongue space and it can relieve mandibular entrapment. But is it safe? You're going to push the teeth right off the bone. And I've heard stories and I've read in the media that if you do this, you're just going to destroy the bony support. And you should never, ever do this. But here's what we're talking about. Proclining anterior teeth like that. Is it safe to do that? Well, if you read the articles inside of these 7 journals, the covers of them, these are 7 refereed articles in the peer-reviewed literature that generally all conclude gingival recession didn't get worse during the orthodontic treatment, where there was even significant proclining of the incisors. So I think if we can extrapolate from that, we'll find out what those of us who've been doing this for a long time have also found is that you don't fall off the edge of the world. You don't push the teeth off the edge of the jaws. It can be a very safe thing to do. So AP expansion is the first thing that's going to go in this other bubble here that helps with enlarging the tongue space. One application of AP expansion is extraction reversal. So when people have had teeth extracted for orthodontic purposes, you can use the same kind of AP development strategy to regain the space and put the teeth back in. And if the teeth were retracted a lot during the treatment where extractions had happened, then this is kind of nice because it can undo a lot of that retraction. So here is a woman who had 4 bicuspids extracted, and there's an appliance that we used for her. And if you look at where those arrows show on the bottom pictures, those are the teeth on implants that were put in after the space was reopened. The profile got a little bit better because the lips got a little more support. So if somebody has really full lips and a small nose and a really weak chin, this may not be an option for them. But somebody whose lips are pretty far behind that line that you could draw between the nose and the chin, called the E line that Ricketts talked about, when the lips are further back behind that line, then this is kind of an invitation to this. Here she is before and after. We didn't push the teeth off the bone. She didn't, have all of this crazy recession that's making it worse. She said, I've had airway problems most of my life. Now I breathe easily through my nose. I sleep well. I don't need a CPAP. I have good overall energy and overall health. Maybe there's some loss of some bone in some areas here, but I can tell you she's not going to have a shortened life because of that at all. And if that's something that just really stings your conscience, then SFOT is one option to consider while you're doing this to just shore up the bone even more. So how you do this isn't the issue right now. We're just talking about what you do. Here's another woman who had the head of the ortho department at a local ortho residency take her tongue space that she had before and change it to that much tongue space after, all in the name of fixing a deep bite. So she had extractions of teeth, and she said while the teeth were being retracted to close those spaces, she started having dreams that she was choking. So that's not a good thing, and she's not the only one that's told me that. So here we are, we've done some extraction reversal, reopened the spaces with AP development. That's the sagittal she used, and she was in tears recounting how it felt to be able to regain that space that she had lost. It really had a big effect on her health-wise. Long story, but it affected her tremendously. So we took her from that much tongue space to now this much tongue space. Does it really make a difference overall? I mean, here she is before and after. Those are the teeth on implants that were added in after reversing the extractions. Turns out, well, here, let me show you this first, the x-ray showing where the implants go in. This is not super easy treatment. Aligning the roots after you've reopened the space, there's some mechanical considerations here that aren't really in the traditional repertoire of orthodontics. So there's her, she probably got a little bit of bone loss from this too, but I can tell you, you don't see it in the mouth, and you don't, I don't think it's going to be an issue long-term with longevity of the teeth. So there she is before extraction reversal on the bottom, on the top, and after the reversal and how much more room the tongue has. And yes, Nicole, there's a tongue tie there. Yep, she needs to deal with that. And in her case, it was documented from before to after that the sleep apnea was resolved. So there's a case there where, it can make a big difference in how much room the tongue has. But the whole reason we're talking about tongue space is we want the airway to function better, and we want overall health to be better. So that can happen. We have to put extraction reversal as the second strategy inside that second bubble there, looking at AP development. You can open spaces like this even when extractions haven't happened, and you create surplus space. This blows the minds of people who've never seen it before. You do this and send them to an oral surgeon, and the oral surgeon says, well, I guess I could put an implant there where there weren't teeth originally. They're like, what do you mean? Of course you can. It's just bone. Put another tooth back in there. It'll reverse previous extraction. It can help with position of the teeth in the face. It can get the tongue more room. A lot of good things creating extra space can do. So deep bite, teeth tip backward. We decided to fix this with a sagittal appliance, bring teeth forward so far there's now enough room to put implants in between the premolars. So there's going to be a first premolar, second premolar, and third premolar. And no one really cares. It's not going to make a difference in his law career that there's more teeth in there. So it increases the tongue space, and this is called extra space opening. And we'll put that strategy along with the extraction reversal. These are all kind of variations on a theme of the AP expansion. Another way of expanding, getting more room for the tongue, is looking at the lower jaw. So as we know, there's no suture there. If you want to do it with the lower jaw, you have to do DO, or distraction osteogenesis. The symphysis of the mandible is that part right where the chin is, in the middle. So think of it this like Sarpy for the mandible. The surgeon just cuts all the way through in between the lower incisors and separates the two sides of the lower jaw. So we abbreviate it MSDO, mandibular symphyseal distraction osteogenesis. The older appliances were placed on the front with screws going into the bone. It held onto the teeth for stability, and that was all covered up, obviously. And you would the patient would make the adjustment to the screw behind their lower lip. The newer design, this is a design patented, devised, thought up by Dr. Reza Movahed, involves pads on the lingual and a screw on the inside. Think of it, this is a lot like the MARPI of the upper, but it's made for the lower. Here's a patient who had that done. It shows the big gap in the bone there after the distraction was done. It shows the airway beforehand. And then here's the airway just from getting the tongue more room with MSDO. In his case, this doesn't always happen, but in his case, the airway improved behind the tongue because that's somewhere else to go. And you can see how the bone fills in there over the months after the distraction is done, the distractor is removed. So MSDO is another strategy, the last one in this little bubble here, for increasing the tongue space, in this case on the lower arch. So let's talk about the blue bubble here, moving jaws forward. The most obvious one is something that's been around for a long time, and that's protraction or forward pulling of the upper jaw to move the upper jaw forward during the growing years, typically. And the younger, the better. Earlier you do this, the more of an effect you can have. So there's a girl whose upper jaw was too far back. It shows just from the outside here what it does to the facial profile. When a kid will wear this well at nighttime and oftentimes during the day as much as they can, it can have a huge effect on how the upper jaw is growing. So when the upper jaw is more forward, the whole reason we're talking about this is we want more space for the airway. As the upper jaw comes more forward, the soft palate comes with it, and the restriction behind the soft palate can be alleviated to a certain degree. Here's a boy who did it, looking at the upper lip there, being more forward. This has been around for a long time. There are lots of different designs of reverse pull headgears or face masks to do this. But one cool application of this is now that we're doing skeletal expansion, like with an MSE here, this is a girl at an age where you would not think she'd ever wear the headgear enough to make a difference. But when the bones have been spread apart and somewhat loosened up from everything they're connected to, wearing a headgear like this at a later age, this can open up new doors to skeletal changes forward that we wouldn't have thought possible in the not too distant past. So getting her to go from there to there might have been something you'd be considering surgery for to get the best result. But when you combine it with the MSE, protraction really made a big difference for her. So protraction, that goes in the blue bubble. It's moving the jaws forward. It's also overlapping the green because it's enlarging the tongue space at the same time. As it comes forward, the tongue has more places to position. Orthotropics is fading in popularity. It's John Mew's baby that he developed in the 70s, and there's really no competition for getting the best growing faces when you compare anybody else to John Mew's changes that he's got. So the goal is to get both the upper and the lower jaws to grow forward during the growth years by means of changing the posture. This is not just about the appliances themselves. It's very dependent on cooperation. It's very dependent on discipline and compliance. And we all know that we have lots of that in our modern world, right? I mean, kids are more disciplined than ever. They do whatever they're told. They do things that are difficult without complaining. They don't really whine or cry. So in that environment, orthotropics will work great. Well, that's not the norm, really. This girl's in a homeschooling family that's very, very well organized, very just a well put together family, and she got a really good change. And when you get that good change from the kid doing their part, it's almost like doing jaw surgery at an early age, but more importantly, it's changing the trajectory of the growth. So the only one teaching this right now is Bill Hang. Karen O'Rourke in Michigan has been teaching it too on a one-on-one basis. It's out there, but it's hard to learn, it's hard to do, and it's hard for the patient to comply with. There's a definite protocol for this. It's not just a random thing where I'm getting the jaws to go forward, so I'm doing orthotropics. There's a defined protocol for it. And even though it's extremely uncommon nowadays, I put it in there as one option. And those of us who do this still consider it something that we'll offer to patients in the right circumstances. Also in that blue bubble of moving jaws forward, the most definitive way to move the jaws forward is with orthodontic surgery. Maxillomandibular advancement, joint replacements, or genioplasty, advancing the chin bone, those are common. Those are options. This has the greatest potential both for the airway and for aesthetics. And then thirdly, also for the joints if it's done right. So it increases the tongue space, and not only by bringing the jaws forward, but also because during the surgery, the upper jaw can be widened at the same time. We call that segmental maxillary expansion. When you do that, the nasal airway can also be expanded or turbinates reduced. It kind of depends on what's needed, but you kind of hit all three of those areas here if orthodontic surgery is done in the right way. So MMA is the term to describe the most common type of double jaw surgery, maxillomandibular advancement. And that involves a Lefort maxillary osteotomy, which means cutting above the upper teeth to relocate the whole upper jaw. And it also involves a bilateral sagittal split. So the blue section and the gray section of the lower jaw are separated from each other and slid past each other and fixed into a different position. That's called the BSSO, sagittal split. When you combine those two together, that's an MMA. So this works really well if you have the right patient. If there's sleep apnea, it can be something that's a huge help if it's done right. Facial asymmetry can be addressed in a way that really no other option can address. If you have healthy joints, you have good prognosis for what's going to happen after you advance the jaws like this. If you don't have healthy joints, then it might be worth considering replacing those joints to make it possible. So when the jaws are way too far back or it looks like it's too far forward, then double jaw surgery, MMA, can be a huge, huge help. And probably the younger, the better, but it depends on what the surgeon's willing to do as far as when to do it. So I'll give you some thoughts on how MMA can be approached in a way that's going to be maximally effective. This is my list of, I don't know how many it is, 11 or 12 things here that we can look at. I'll just hit them very briefly. The first is you always do orthodontics before and after. I was popular in a local teaching institution near me to just do the surgery and then let the orthodontist clean up the mess with orthodontics afterward. That you really limit the benefits of surgery when you do it that way. Second thing is 3D virtual surgical planning, a VSP, where everything's planned out down to the millimeter and the degree of movement. This is kind of the standard of care now. So it's going to give you the best idea of where things are going to move and what the face is going to look like and things like that. Pretty much always, you want to treat both the upper jaw and the lower jaw. It's an extremely limiting type of procedure to only move one jaw because it's not like one is in the exact right place and the other is not. So especially if you're doing this for airway reasons, treating both jaws is going to get the best result. Sometimes you want to open up spaces between teeth ahead of time. That whole AP expansion category we were looking at, in this person's case, missing the upper laterals, reopening the spaces there gave the opportunity for a wider upper arch. So the question is, where would we want to open up spaces? Maybe distal of the canines, distal of the first five, a lot of factors to consider there. There are cases where we'll actually extract teeth before surgery and then retract and pull back all the front teeth in front of the extraction there. This is like the worst thing you could ever do to somebody you hate if they're not going to do surgery. But if they're going to do surgery, this allows maximum forward movement of the jaw if the teeth are further back in the jaw. So the further back in the jaw the teeth are, the further forward the surgeon can move the whole jaw. Expansion, maybe you do it before surgery. Maybe you're going to have to do some after. Should you do the upper, should you do the lower? A lot more commonly now, we're doing MARPE skeletal expansion ahead of time so that we can get a head start on whatever the surgeon might be able to do with expansion. Or an MSDO on the lower. Or this hyperdrive allows the maxilla to be brought forward before surgery so that the maximum forward movement can happen with the upper jaw, like in a cleft palate patient. So there's only a certain distance a surgeon can move the jaws, given the limitations of soft tissue, blood supply, and all that. So there are things like this can maximize what will happen during the surgery. So they say MME, then MMA, maxillomandibular expansion, and then maxillomandibular advancement. Counterclockwise rotation of both jaws. This can be visualized if you look at the occlusal plane from the side. It's kind of steep there. And a good surgery can take a steep occlusal plane like this and rotate both jaws counterclockwise to make it more of a flattened occlusal plane like this. And there are criteria that they use for the angle to Frankfurt horizontal and all that. A very flat occlusal plane to start with may not allow for this to happen very much. But it's doing this that can open up the airway, especially behind the soft palate, and even more behind the tongue. So here's what a counterclockwise rotation looks like. Watch that section of the mandible in the middle there rotate as it's coming forward. That's the movement. Counterclockwise rotation of the mandible. Total joint replacement. If the surgeon knows how to do this, then this opens up possibilities that wouldn't otherwise be there. The jaws can be moved much further forward with much greater stability, knowing the joint's not going to be like the foundation of the skyscraper here in San Francisco that's sinking into the mud and tipping now, and everybody's pointing fingers at whose fault it was. Well, it's not an uncommon thing to see after double jaw surgery that the foundation sinks into the mud and the lower jaw drops backward because the joints don't stay stable. So TMJ Concepts in Ventura here in Southern California makes this prosthetic joint here. It's been really helpful for a lot of my patients. I've seen a lot of predictability in cases where it wouldn't otherwise really work to treat them with traditional surgery. Here's another strategy to consider, subapical corticotomy. So imagine that whole section of the mandible in the box there being moved backward. So basically a cut is made below the lower incisors and distal of the lower canines, and that whole section of bone and teeth is moved backward. So look at the right picture. You can see after it was done, there's that step between the part that was mobilized and moved backward and the part below it. So subapical corticotomy is another way to maximize how far forward the lower jaw can be brought. If the teeth are further back, the jaw can be brought further forward, and that's what opens up the airway. Segmental maxilla. As I said, during the surgery, we can leave a little space between the laterals and the canines, and then the surgeon can make a separation between the four incisors in the front and the back segments, and he can control what angle they're at, how far they're widened, whether it's symmetric or asymmetric. A lot is under his control with that. And then after the surgery, or during the surgery, I should say, he'll place a stent. It's basically a splint to hold the upper jaw where he put it. It's wired in place, left there 3 months at least, and the bone heals around. It's like a cast on a broken arm. That's called a segmental maxilla. He segments the maxilla during the surgery. So here's a patient who had a counterclockwise rotation of the mandible. He had total joint replacements. He had the subapical corticotomy to bring back the lower anterior incisor segment, and he also had a segmental maxilla. And the results were huge, going from airway before to after, but also looking at the face, just the balance of the face there. You don't get that with just your standard MMA type of procedure. And the total joints were a key to this for him too, because it allowed the mandible to be positioned the right way and be stable in that position. During the surgery itself, certain types of ENT treatment could be done to reduce the turbinates or affect the septum. So this is where enlarging the nasal airway might be something to be done at the same time. Pulling the chin forward where the genioglossus muscle attaches on the other side, that can pull the tongue forward so it's out of the airway as well. So last thing on my list here is when, not whether, but when you do myofunctional therapy, before and after surgery. So these are all things that affect the success of surgical cases. And these are not all the standard of care. Most surgeons don't know how to practice all of these different techniques here, or maybe if they know it, they just don't do it. But what I've seen in a lot of surgical cases is if you do the right combination of these things, it can add up to a lot of success. This was a nightmare of an airway that when you analyze it in treatment studio, the smallest cross-sectional area is 22 square millimeters. And the alarm that goes off in your head when you see a small airway like that, and you think, well, the sleep isn't all that great, and there is definitely snoring, and sleep on the back is impossible. You can kind of understand why. Well, that was me in February of 2022. And the minute I saw this scan, I thought, I got to head towards surgery myself. So I got my records done, got separators placed, had a surgical plan done for what was going to be done, all those things we were just talking about. And that was me 1 day before and 3 weeks after doing double jaw surgery for the sake of my airway. And I didn't do it for looks. I mean, On the inside, you don't see all this, but there's a custom plate holding the maxilla where it goes. There are the plates holding the lower jaw. And the reason I did it was not so that I could, have a stronger chin or change my profile. It was really more about the change that I got underneath all of this. I had to redo my picture that I use for my professional stuff. 12 times increase in the airway dimension, went from 22 to 266. So it made a huge change in my life. There were downsides like the cost and the hassle and not being able to eat whatever I wanted and some other things there. But the upsides to me definitely outweighed the downsides. My sleep is way better. I figured if I don't do this when I'm 61, I'm not going to live to 71, 81, 91. So I wish I could have done it 10, 20, 30 years ago, but better late than never. I think there are a lot of advantages that to me definitely made it so it was worth it. And I would do it again in a heartbeat without any doubt. So I've got personal experience with that, not only with all my patients who've done it over many years, but with myself too. And kind of helps me be able to talk to my patients about it. Finally, the last section we're going to talk about here is, you all know who that is, right? The Hippocratic Oath, do no harm. Hippocrates said, at least don't make things worse. And that's the orange bubble here, preserving the tongue space. And like I said, Nicole, preserve and enhance the tongue space when you can. So this is like the bare minimum. If somebody's going to say they're at least airway aware, they need to at least be thinking about preserving the tongue space. So non-retractive alignment is the strategy that preserves the tongue space. Don't pull teeth backward in the mouth in a way that reduces the tongue space. Companies that set up aligner strategies for you, aligner plans for you, like Invisalign or Spark, they will routinely do things that reduce the tongue space. And with braces, we routinely do things that reduce the tongue space. So in non-retractive alignment, we're trying to preserve the width and the length of the arch. Don't do anything to make it smaller. If there are spaces, close them by moving teeth anteriorly, move the teeth forward and move the spaces further back, or use pads to pull teeth forward. So an old plan might have looked like this on the left. See how that just totally reduced the tongue space. A new plan looking at non-retractive alignment might look something like this. The arch size, arch dimensions stayed the same, side to side and front to back. Yes, there's space in there, very observant, there's space, and it turns out you can deal with that space. There are options. This not only reduces tongue space to retract, but as we were saying before, it also can cause mandibular entrapment, that pulling back of the front teeth so that the mandible ends up distalized. So it's really to avoid both of these negative things that we will want to do any alignment that we do, any orthodontics we do, in a non-retractive way. So here's a young girl who had spaces between a lot of her teeth. In the pictures on the left, you can see the spaces. And basically what we did was we took that space distal of the canine and moved it in front of the molar. We took that space and did the same thing. On the lower, we moved that space in front of the molar. So it's just shuffling teeth around to move where the space is so the dimensions of the arch don't get smaller. And with a good, arch wire in place, the arch dimension, it's a broader arch, definitely, just by doing the alignment with the braces, but nothing was retracted. So what do you do with the space that remains? Well, if it's really small and it's not catching food or causing a hygiene problem, you just leave it alone. There's a lot of my patients just go, yeah, it doesn't bother me, I'll just leave it there. You can just rinse your mouth out and the food comes out of there if there is any food there. Generally, it's not a functional problem during chewing. If the space is bigger than that and either somebody objects to how it looks or they just want added stability for their tooth position by filling in the gap there, you can do that with resin. Bonded resin can fill in the space. If you look closely at those lower premolars, they've been made wider mesiodistally to fill in that space there. And here's the same patient on the same day, before and after, doing bonding resin on the upper and the lower to close those spaces. So it can be done in a way that's aesthetic as well. Or option 3 on the far right there, when there are larger spaces, just put another tooth in, put an implant in. If there are crowns on the teeth around the spaces, redo the crowns and make them into fixed bridges. That's not as common now, but you just put another tooth in. So those are ways of dealing with the space that remains if you don't close it all. We're just taught so much that we have to close all spaces that this doesn't enter our frame of thinking, that it's okay to leave space somewhere. Non-retractive alignment, that was number 10. But before I move on to number 11, I want to talk about retraction again in a little more detail, because there's a question of, why would we pull backward on the teeth in the mouth? Why do we retract? Why would we? What excuse do we have for retracting? The first one is that we want to reduce overjet. We want the front teeth to be closer together, and the upper front teeth are often looking like they're sticking out. We know now that they're not. If anything, they're too far back. They're not too far forward. But we want to reduce overjet. And we have this thing in occlusion about canine guidance and anterior guidance. We want the front teeth to be closer to each other. So this is a really common reason we retract. We've been trained to believe that class 1 molars are the only possible goal of orthodontics, and it's one of Andrew's 6 keys: correct the molar relationships. So we retract to get class 1 molars. Or if there's spaces between the teeth. The simplest way to close space, the most common way to have space closure, is you just pull everything in together and backward. It's that closing everything backward to close spaces, to get tight contacts that makes us retract. We might think that there's really no alternative than retraction to deal with space problems and crowding. We might think the profile is too full, in quotes, because it's usually the chin that's too far back because the lower jaw is too far back, or maybe it's a smaller nose for an Asian or Black person. That's just normal for them. And we're punishing the teeth and the mouth for the fact that the chin and the nose might be further back for other reasons. So flattening a profile is not a good reason to do this, but we use that excuse all the time. Cephalometric norms tell us, well, this tooth should be at that angle to that plane, and in order to get the right stability, for which there's no study to prove that stability exists, and it's going to be so stable, maybe we won't need retainers the rest of our life. No, we didn't say that, because you have to wear retainers the rest of your life if you want to be sure you're not going to have relapse. But we're given the excuse that if we don't satisfy certain cephalometric angles and positioning of teeth, that it's not going to be good. So we have to retract teeth. And now we're seeing the same thing with 3D imaging, saying, oh, well, there's only bone here, so we have to retract in order to work around where there's bone. But we really shouldn't retract. Why? Big reasons, some very big reasons. The first one we've already touched on, because you can adversely affect the tongue space and the airway. And here's a study out of China that talks about how as front teeth were pulled back, the airway got smaller on 3 different levels. Second reason, we already talked about mandibular entrapment. We should avoid it. It leads to TMJ problems. It leads to other bad things. So not trapping the mandible would involve not retracting in a lot of cases. And there's a whole lot else about life that is affected when we take a patient and we pull their teeth backward in the face with whatever means. And when I was a kid, it was a headgear. Now it's the Hertz. For other people, even the trainers that we use can be retractive. And this can have major effects on adults who will tell you stories about what they think it did to wreck their face, to make them feel like they can't bite, and it messes with them emotionally too. So Bill Hang came up with this term, extraction, retraction, regret syndrome. And just go onto the Facebook group Extraction Reversal and meet some of the people and how it's affected their life to have extraction and retraction. It is not everyone. It's a subset. It seems to be the majority, but no study's really been done beside Karen Bach. She's a PhD researcher that's interviewed thousands of people who've had extractions of premolars and retraction. And about 30% say no negative effects on them to speak of. But the other 70% describes in excruciating detail the effect it did have on them. So it's more than just you're losing body parts. It's more than just the airway's going to get smaller. It affects people's lives overall. Yeah, but it doesn't happen all the time. It's only some people this happens to. All right, well, until you can prove to me that there's no risk doing this, we should never retract, because we don't know how much retraction is okay on any patient. And believe me, sometimes it's a very small amount. 1 millimeter can make the difference for somebody's comfort or discomfort. And we're not really taught that, and we don't think that way with traditional orthodontic tooth movement. So it's too big of a risk to take. It's probably, since you can't prove when it's safe, don't do it, because for a lot of people it's not safe. So if we're going to categorize the things we do into those things on the left that have low to no risk of retracting and causing those bad things we were just talking about, or other things that we do that do definitely have a risk of retraction. Maybe they don't always retract, but there's definitely a risk of retraction and a risk of reducing the tongue space. There are a lot of things that go in this category on the left, and this is not an exhaustive list, but a lot of the appliances we use, especially the things that expand, they're not retractive at all. And a lot of them, like the reversible headgear, it's going the opposite direction. But then there are other things we do, even in what's quote unquote described as an airway practice, that do definitely have a risk of retracting because they put a backward force on teeth. Usually it's the upper teeth, like the Herbst, Invisalign Mandibular Advance, and the Invisalign MA, the Mara, Class 2 elastics, all those things put a backward force on the upper teeth and the upper jaw and have a risk of retracting. And that's not good. So if our goal really is to avoid causing a problem with the airway, and we don't know how much retraction might be okay and before it's going to cause a problem, then really it's better for us to just stop any technique that would cause retraction. So to me, this is kind of a public service announcement that needs to be out there. Give the orthodontist permission to leave the molars not class 1. Give them permission to leave a little overjet. Give them permission to leave some spaces, because this goes against every grain in their body to do that. And yet, in the bigger picture, that's probably what should be done. And if you're a myofunctional therapist or any other health professional where you're in the mouth looking at what's going on, this downward, backward growth of the maxilla is an easy thing to measure with John Mew's indicator line, the distance from the tip of the upper front tooth to the tip of the nose. If you just measure this for your patients before, during, and after treatment, and you see this line getting longer on a non-growing patient, that means retraction was taking place. This is a very easy measurement to take and to look at. So here's a patient. This is the one I was starting to tell you about earlier, where I used a Herbst appliance to correct that overjet. And I got the overjet reduced. I mean, to me, I was pretty happy with that. I got the molars in a better relation. He liked the look. He didn't feel like his front teeth stuck out. But after listening to Bill Hang, I went back and looked at some x-rays, and this was one among others where the airway actually got smaller after the treatment. I think retracting the upper to the degree I did decreased the tongue space and made it get worse. If I had been measuring, like you could do this now with your cases, if I had been measuring from his tooth to his nose, I would have seen that the indicator line got bigger. I was retracting the upper teeth. So avoid retraction, watch closely to make sure you don't do it. Finally, the last thing is overjet camouflage. This is kind of another thing in that category of not making things worse, but it's a way of dealing with that overjet that can be acceptable to patients, not all of them, but a lot of them, without doing any retracting. So we're advancing front teeth to mask the overjet, and it's going to create spaces. If it's a class 2 case, it's essentially just bringing the lower teeth forward within the jaw that's too far back, and it would look like that. It looks better in the smile, and patients will often prefer this to the way it looked like this, but the trade-off is there's now going to be some extra space in there to deal with. Case 1 on the left, overjet was reduced by bringing lower front teeth forward. A small space remains between the premolars, and it doesn't bother them. They're just going to leave it there. The case on the right, that overjet was not acceptable to this woman. She was a realtor, and she didn't want to do jaw surgery, so we did class 2 camouflage, brought the lower front teeth forward, and she needed a crown on this first premolar anyway, so I think there was a crown done that was just made wider to fill in the space there. So you deal with the space however you want to deal with it, but the key is you're bringing front teeth forward. Remember those studies that showed that proclining lower anterior teeth was not a major issue with recession. And even in this case, you look at it, it's not like to this day, she doesn't have recession in those lower front teeth. So you got to deal with the space, either leave it or restore it. Turn the whole thing upside down and you get class 3 camouflage. And In this case, it's advancing the upper anterior teeth in order to hide a class 3. So it's basically doing that. And there's a young man here with Down syndrome who probably would have been told he needed jaw surgery. And as the teeth were all in, we advanced the upper anterior 6 teeth and made room for the implant. So class 3 camouflage is another strategy within this category of things where you're at least preserving the tongue space. And actually, the camouflage treatments do somewhat enlarge the tongue space. But that wasn't really necessarily the direct goal of that. It was mainly just don't make it worse. So non-retractive health-centered orthodontics is all about making the tongue space and the airway bigger, not doing anything to reduce it, but at the same time, you have to work toward nose breathing and proper oral posture and function. And this is where myofunctional therapy is another piece to the pie here, but you can't have our piece to the pie in orthodontics without having that whole the whole area of oral dysfunction in posture and posture, swallowing, breathing. That has to be addressed as well. So yes, orthodontics is way more than lining up teeth. It can have a major impact on health, for better or for worse. To me, you look at these strategies of making the tongue space and a nasal airway bigger, moving the jaws forward. It's like looking at a menu. What is it that's going to fit for this patient? These are the things that we can do in airway, non-retractive airway orthodontics that can have the biggest impact on somebody's overall health because of what they do for airway function and sleep, and then the big picture beyond that. So thank you very much for your attention. I appreciate it, and look forward to answering questions.
Wow, wow, wow. That was so amazing. That was probably one of the best lectures I've ever heard. Yeah, wow. Okay, that will help anybody understand the entire scope of orthodontics in terms of that non-retractive, health-centered airway approach. That just like answered everything. Thank you so much for all of that. There were so many interesting things. One question I have is, if someone has like a skeletal expansion treatment, you're kind of saying it's not as important to decompensate the teeth because you're risking losing some of the tongue space by uprighting the teeth.
It's not that it's not important. It's that it might be a lost opportunity. So what Nicole means when she says you're talking about decompensating the teeth. So when we expand the whole maxilla, if the lower teeth now don't match up with the upper teeth, the common way this is fixed is by bringing the teeth inward to match up with the lower arch. So this can be a good thing because it allows more expansion of the upper. But the way I see it being done a lot of the time is it's done without expanding the lower. So I kind of feel like if there's an option to upright the lower teeth and decompensate them, that will often make less of the decompensating of the upper necessary. Does that make sense? So it's still okay to do it.
Yeah,
but,
and for example,
but if you don't have to, it'd be better not to.
Mm-hmm. And if like the upright, if the upper central teeth are sort of flared forward and they want to use Invisalign to upright them, now you're kind of risking losing some tongue space and retracting the mandible a bit.
Yeah, exactly. If there's no overjet, you're for sure going to risk entrapping the mandible. And even if there is overjet, as you bring them back like this, it's reducing the tongue space. So
you can kind of leave things flared. Yeah, tell me it would be better if what?
Better to leave them slightly proclined and just bring the teeth together to close any spacing that might be there, and even leave the overjet there. I mean,
right.
You don't die of overjet. And this the hardest part about this whole thing is communication and setting expectations with the patients and their parents. So we're not just going to all of a sudden say at the end of treatment, yeah, you've got that space there. Don't worry, that won't hurt anything, because that's not going to fly. The parent's going to say, well, wait, you're done? You're going to take the braces off and there's a big gap right there? It doesn't look to me like you're done. My friend who's an orthodontist looked at it and said, it's a long way from done. So this is difficult to manage in terms of setting expectations. For a specialist, you got to deal with the referring general dentist and make sure they're not going to undermine what you're doing. And if you're the general dentist, of course, the patient and the parents have to be on the same page.
Yeah. Wow. So much. There's so many details to this. That was so and another really important lesson I learned is that we don't have to be black and white with quote unquote true expansion, whether dental alveolar is not true expansion because it's not skeletal expansion. There's that third option. Like you said, you are getting some sutural change, some sutural growth, and there's some degree of remodeling, and the tongue doesn't care where it gets the space. Doesn't really matter in many cases. It just needs more space. So that was a really interesting perspective on that. And yeah, that was awesome. I think I'm going to listen to that like 10 more times, and that would be helpful for patients, parents, practitioners, myofunctional therapists to listen to this, to grasp the full scope of this non-retractive airway focused orthodontics technique. So I thank you so much, Dr. Hockel, for all of your time.
You're very welcome. I appreciate the opportunity, and it's always great working with you, talking to you, and kind of bouncing ideas off of each other, because you're such a leader in the field, and you put the areas of your expertise in such a clear way that it's inspiring to us too. The rest of us who teach is make it clear and try and get the message across in a way that that will make an effect on what we do.
Thank you. Well, I feel the same thing about you. That presentation was outstanding. Thank you so much, and have a great weekend. Thank you.
You too. Yeah, okay.
Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much, and join us for the next one.